So here we're going to talk about the colon disorders and surveillance, namely surveillance for colon cancer, which is perhaps one of the most preventable cancers in the United States. So we've come to the end of the digestive tract. We're talking about disorders that affect the large bowel. So breaking this down, what we're going to talk about in this section, we're going to talk about the diverticular diseases, we're going to talk about constipation, and then we're going to talk about colon cancer as well as some of the disorders that give you a higher probability of developing colon cancer. Starting with diverticulosis, so diverticulum is where the word diverticulosis comes from, and a diverticulum is just a general term for an outpouching of a lumen. So generally the way diverticuli form is that there's a pressure inside the lumen, and what's surrounding the lumen is not strong enough to hold that pressure, and so part of the lumen will outpouch into outside of whatever is holding it. And that's basically what happens in diverticulosis, is that a pressure develops in the large intestine, usually in the sigmoid colon, and it causes part of the lumen to outpouch into the surrounding space. So there's no change in the actual lumen itself, it's just the actual anatomy of the bowel. So you have a pouch, that separates this one part of the bowel from the rest of the bowel. Usually diverticulosis is asymptomatic and it's extremely prevalent. I would say that probably a majority of adults in the United States over the age of 50 have at least one diverticulum in their sigmoid. So it's usually asymptomatic. Very, very, very rarely can it cause left lower quadrant pain. And left lower quadrant is not a common place to have pain. Unless you have generalized abdominal pain, to have localized left lower quadrant pain is not very common. And so when you hear left lower quadrant pain, I want you to associate that with the diverticulum, with the sigmoid colon, because that's a very unusual place to have pain. Another thing to associate left lower quadrant pain, as far as left lower quadrant in that area, is ovarian OBGYN pain. But on the USMLE, if they tell you left lower quadrant abdominal pain, then you should definitely associate with diverticulosis. With diverticulosis, there's never going to be fever. So we're going to compare this to diverticulitis in a little bit. But with just plain simple diverticulosis, it's usually asymptomatic and there's very rarely pain and there's never fever. Usually this is just going to be an incidental finding when you do one of your surveillance colonoscopies. So when your patient's 50 and they're ready for their first colonoscopy and you go in, sometimes you might see a diverticulum, and they're pretty apparent when you see them on colonoscopy. When you find a diverticulum on colonoscopy, you should make note of it, and you should certainly advise the patient, because the fact that they have a diverticulum puts them at risk for diverticulitis. There's no acute therapy necessary for diverticulosis, but you should educate the patient about increasing fiber in the diet and possibly using over-the-counter bulking agents like Metamucil or psyllium husks. Those can be useful for reducing the probability of developing another diverticulum. It won't get rid of the current diverticuli, but it will reduce your risk of developing further diverticuli. And the more diverticuli you have, the greater your risk is for developing the complication of diverticulitis. So definitely make sure to educate the patient about increasing fiber in the diet. 9 out of 10 Americans do not get the recommended 20 to 25 grams of fiber in their diet daily. And so for most patients, they're going to need an increased fiber in their diet, but definitely the patients with diverticulosis. This is really a disease of the West. In the East, they don't have this so much because they don't have the processed foods that we do here. So in India, diverticulitis, diverticulosis would be a zebra. Here, it's practically the norm. So that just kind of shows a difference between Western society and Eastern society and how that reflects in medicine. For the USMLE, diverticulosis and diverticulitis are going to be crucial. So here's diverticulosis on colonoscopy. This appears to be the either ascending or descending colon on the right here. And this looks like this is definitely the sigmoid colon on the left. So here you've got 1, 2, 3, 4, 5, 6 diverticuli, 7 right here. Here you've got 1 and probably 2 here. So you're not going to be doing a colonoscopy for the diverticulum, but what you will be looking for is colon cancer. When you're doing your colonoscopy, you're going to be looking for polyps. But if you see a diverticulum, you got to make note of it and let the patient know. Okay, so what's the complication of diverticulosis? It's diverticulitis. Diverticulitis is when one of those diverticuli get blocked, and when they get blocked, usually there's fecal matter in there, and the fecal matter will cause an infection, and the blockage will usually occur from non-digestible food products. So hulls, corn, and gum. Another reason not to swallow your gum, especially if you're older. So this will present with pain, and it will usually be left lower quadrant pain, but it can radiate to be periumbilical or left upper quadrant pain. It's really hard to, or pelvic pain. It's not always going to be in that nice localized quadrant, but it should be more towards the left and down lower towards the pelvis. There will almost universally be fever in patients with diverticulitis. I would say universally on the USMLE, but not always. But they will tend to be a higher grade temperature. As far as diagnosis, if you suspect diverticulitis, the very first thing you should do is get them an abdominal CT. And this can be done with or without contrast. If you want to use contrast, then you should use oral contrast. You will never, ever, ever, ever use a barium enema, and you'll never use a colonoscopy. And there's 2 reasons for this. 1, you have an increased risk of perforation. 2, in addition to that perforation, if you gave the patient a barium enema for contrast, what you might think would be what you want to do because you're trying to visualize the sigmoid in particular. These patients who have diverticulitis have a very high risk of perforation. And if you inject barium up into their bowel, you can cause the barium to spill into the peritoneal space. And that can result in a catastrophic inflammation. So never do a colonoscopy and never give a barium enema or any kind of enema in patients with diverticulitis. You're going to do an abdominal CT for diagnosis. And if you use contrast, you're going to use oral barium contrast. It's also a good idea to get labs in these patients because you want to check for elevated white blood cells. As far as the therapy, all of these patients are going to be admitted. Most of them are going to have severe pain, and the abdominal CT should be pretty indicative for diverticulitis. You might not see the actual inflammation itself, but the fact that you have left lower quadrant pain in addition to diverticuli should be enough to make the presumptive diagnosis of diverticulitis. When your white blood cells come back as elevated, that will be a confirmed diagnosis. The medication that you're going to use is really the same medication we use for any disease, diarrhea of the large bowel, of the small bowel. It's going to be ciprofloxacin and metronidazole. They have an incredible broad coverage, so if you ever get a GI question, lower GI question, as far as small bowel, large bowel, diarrhea questions, and they ask you what antibiotics to use, ciprofloxacin or ciprofloxacin and metronidazole will usually be your right answer. In addition to this, you're going to want to advise the patient, just like any patient with diverticuli, that they should have a fiber-sufficient diet, at least 20 to 25 grams of fiber per day. And this is a CT. This is one with oral contrast, presumably. And you can see here the diverticuli. The contrast doesn't get into the diverticuli. And this is the sigmoid here. You know it's the sigmoid because you have the hips here and the musculature. And here's the rectum. And this is the S of the sigmoid. Okay, let's move on now to constipation. So constipation technically is less than 3 bowel movements per week, but so there is a technical terms and technical criteria for constipation, but really you should go by what your patient says. If your patient says they're constipated, get a little bit of additional information from them, but generally when a patient says they're constipated, that's a diagnosis of constipation. What you really do want to know, though, is do they mean they're constipated because they haven't had a bowel movement in a long time, or are they constipated because it's difficult for them to have the bowel movement? Either or can make up the definition of constipation. So it could be decreased frequency of bowel movements, or it could be straining and hard, lumpy stool. The diagnosis is on clinical grounds. There's no lab, there's no imaging we can do to diagnose constipation. It really is just a subjective diagnosis. The causes are going to be what's going to help you in the therapy. So the various causes will help us reverse the aggravating cause, and that's going to help us treat the patient. So the number one cause of constipation in anybody is going to be dehydration. In addition to dehydration, another thing we see in patients, particularly in the hospital, well, we hope we don't see dehydration in the hospital, but what we do see in the hospital a lot, and why patients are often constipated in the hospital, is sedentary conditions. So patients who are bedridden, patients who are paralyzed, patients who are in nursing homes, they're all at risk for constipation. Diabetes mellitus is another risk factor for constipation, and that just has to do with the autonomic neuropathy. Iron supplementation is another risk factor for constipation. Only approximately 2 to 3% of iron that's taken orally is absorbed. The rest of it goes out in the stool. And this can gunk up the large bowels. Certain drugs can cause constipation. Which drugs? The number one that should be on your mind is opiates, and that's a big problem. Patients who are in pain are generally taking opiates, and they're usually not moving around. So opiates plus sedentary condition is a cocktail for constipation. Calcium channel blockers can cause constipation just because the fact that they inhibit some of the neuronal input to the large bowel. Anticholinergics, because they're sympathomimetics. Antacids can cause constipation as well. Don't ask me why, but just know that they can. And, of course, other sympathomimetics like pseudoephedrine. A lot of patients who are on pseudoephedrine over the counter, so there's a risk that the patient could be overdosing on pseudoephedrine. So you want to make sure, if the patient is constipated, to know what drugs they're on, because usually drugs will be a cause. So dehydration, sedentary condition, diabetes, iron supplementation, drugs. Another cause is hypothyroidism. So I wouldn't go ahead and investigate for hypothyroidism unless there's other signs of hypothyroidism like weight gain or decreased appetite or depression. But know that constipation is a symptom that could lead you towards a presumptive diagnosis of hypothyroidism. And then neurologic disorders can cause constipation as well. The treatment for constipation is going to be symptomatic, and you're going to be focusing on minimizing those offending agents. So if you can stop opiates, you would want to. Switch them off into NSAIDs. If the patient's dehydrated, you want to ensure adequate hydration. Psyllium or Metamucil is a great way to increase fiber in general, and that's going to draw out fluids into the large bowel and get things moving. You can also use the laxatives, docosate, bisacodyl, polyethylene glycol. Those will all be fine for the short term, but you don't want to use those long term. And if the patient has other symptoms in addition to constipation that point you towards hypothyroidism, like I said, decreased mood and affect, weight gain, then you're going to want to consider getting a TSH and T4. And the differential here is going to be irritable bowel syndrome. Irritable bowel syndrome isn't just simple constipation. It's constipation that's painful and has lasted more than 3 months. and the pain is relieved with a bowel movement, and often it will alternate with diarrhea. And there's a section on irritable bowel syndrome, so look at that for more information. All right, now we get to colon cancer. So colon cancer, and when I say colon cancer, what I mean is colon adenocarcinoma. It's one of the more common cancers in the United States, and it has a lifetime prevalence around 5 to 6%. So if you get a room with 20 people, more than likely, statistically, one of those people will develop colon cancer at some point in their life. The risk factors for colon cancer, apart from genetic, are widely unknown, but there is a slightly increased risk with red meats and a high-fat diet and smoking. But in general, most colon cancers happen idiopathically, not in any patient that has a very, very high red meat diet or a very, very high fat diet, although most of us do with our American diet. Generally, it's idiopathic. So the fact that there's a slightly increased risk with red meats and a high fat diet doesn't mean to cut all red meats and cut all fat out of your diet. Of course, it does mean stop smoking, but there's other reasons for that. Now, the risk is greatly reduced by proper preventative measures. And by proper preventative measures, I mean colonoscopy starting at the appropriate age, which in general is age 50. And the symptoms of colon cancer are going to be depending on the location of the tumor. So where the tumor is going to play a significant role in how we diagnose the cancer. And usually the left-sided tumors are going to be the tumors that are more obvious. And the reason they're more obvious is because they change the stool caliber. Starting here in the cecum, when we get everything from our small intestine, the stool isn't formed at all. It's primarily liquid. By the time we get, so remember, going through your bowel, you're absorbing fluid. By the time we get to the sigmoid colon, most of the stool is formed and is firm. So it's important where the tumor is. If the tumor is on the right side, you're going to have normal looking stools. If the tumor is on the right side or in the sigmoid, you're going to have stools of a narrower caliber, and that's just because you have a tumor that's pressing up against the stool, and you're getting a smaller diameter stool coming through the rectum. And so a narrower caliber stool is a sign of a left-sided tumor and very, very indicative of colon cancer. But you don't necessarily have to have a narrow caliber stool to have colon cancer, because it could be on the right side where you would have normal caliber stool. In both sides, you will get heme-positive stool and you will get anemia as a result of that. On the left side, you'll get either occult blood, so no blood visible, or you could have visible blood. And that's simply because if you're bleeding from the tumor on the left side, you're not going to have any time to deoxidize or to oxidize that blood, and so it will come out maroon or bright red. On the right side, on the other hand, you'll have red blood coming out, but by the time it gets through the entire colon, then it's going to be dark, and so you won't see it. So right-sided tumors are generally more difficult to diagnose symptomatically. Left-sided tumors tend to present more dramatically as far as symptoms. And because of that, left-sided tumors are usually going to present earlier, and they're going to be have a higher survivability rate. Okay, so going back to as far as how you diagnose colon cancer, it's going to be with colonoscopy. Definitely if a patient has any of those alarm signs like narrow caliber stool or a positive hemoccult test, colonoscopy should be something to consider. The treatment is going to, for the colon, so if a patient's diagnosed with colon cancer, you have done that with colonoscopy and biopsy, that should be included here, colonoscopy plus biopsy. The treatment is going to be resection. If it's localized, if it's widespread, you should use chemotherapy in addition to resection, but definitely chemotherapy. And the particular agent you're going to use is 5-fluorouracil, and that's for most GI tumors. So remember, you also use 5-fluorouracil in esophageal tumors. As far as surveillance, so this is going to be really important for the USMLE because the USMLE wants you to know how to treat patients who are healthy, how to keep your patients from getting cancer, how to take care of your patients in the clinic that you see every year. So routine surveillance, which is colonoscopy, is recommended for all adults beginning at age 50. So everybody should be getting colonoscopy after their 50th birthday. And this will continue every 10 years. So at age 50, at age 60, at age 70, and so forth. If a polyp is found, then the colonoscopy will be repeated every 3 to 5 years until you don't find a polyp anymore. So if you do a colonoscopy at age 50 and you don't find a polyp, you do it again at age 60. If you find a polyp at age 60, then you're going to do it again in 3 to 5 years. And a gastroenterologist may do it at 3 years, they may do it at 5 years. It really depends on the gastroenterologist. But just know if a polyp is found, you're going to repeat your colonoscopy in 3 to 5 years. Now, let's talk about the abnormal people. If a patient has a family history of premature colon cancer, and when we say premature colon cancer, we mean colon cancer before the age of 50. Why do we start doing colonoscopy at age 50? Because colon cancer happens after age 50. If it happens before age 50, it's premature. If a patient has a family history of premature colon cancer, then you're going to start colonoscopy screening at whatever age that relative was diagnosed minus 10 years. So if your mom was diagnosed with colon cancer at age 48, then you're going to be getting your colonoscopy, your very first colonoscopy, at age 38. And then you're just going to be continuing every 10 years, and if a polyp is found, then you repeat every 3 to 5 years. It's the same surveillance. So the only thing that changes if you have a family history of premature colon cancer is the age you start doing the surveillance. There is a umbrella term called hereditary non-polyposis syndrome, and what this is a significant history of colon cancer. So significant family history of colon cancer. And there's 3 things that need to happen. 1, you have to have 3 or more relatives that have been diagnosed with colon cancer at any point in their lives. And so here we're talking about cousins, first cousins, siblings, grandparents, brother, sister, and so forth. 3 or more relatives diagnosed with colon cancer in 2 or more generations, so like your mom and your cousin, your grandma and your dad. It's got to be in 2 or more generations, and then at least one of them have to be premature. So 3 or more relatives in 2 or more generations, and at least one is premature. Any patient at whatever age they are who fits this criteria is considered to have hereditary non-polyposis syndrome. So if it's a 7-year-old girl whose mother developed colon cancer at age 45, her grandpa had it at age 60, and her uncle had it at age 55. There you have 2 generations, 3 relatives, and one of them was premature, her mother. That girl is going to get her first colonoscopy at the age of 25, and that unfortunate girl is going to be getting a repeat colonoscopy every 1 to 2 years. So surveillance colonoscopy starting at the age of 25 and repeat every 1 to 2 years for this very specific history. So what does colonic polyps look like on colonoscopy? They are just these little balls of tissue. Usually you'll just see 1 or 2 on a surveillance colonoscopy. Sometimes you don't see any. But you really can't make the diagnosis just based on how they look. So what the colonoscopist does, usually it's a gastroenterologist, occasionally a surgeon, is they scope the endoscope down into the bowel, and they've got a little tool. They call it a snare, and it's just a metal ring, and it goes through the colonoscope, and they can loop it over the polyp and pull it out. It cuts it off, and it pulls the polyp through the back through the colonoscope and then into a jar. And then that polyp will be assessed by a pathologist. Now, this is just FYI. These are the four of the different types of colonic polyps. What you should know, though, is the hyperplastic polyps, those are not malignant. So those are the good polyps, quote unquote good polyps. You still have to reassess those patients in 3 to 5 years, though. The pre-malignant polyps, or the bad polyps, are tubular, tubulovillous, villous, and sessile serrated. And villous are the worst. So these are the ones that are most likely to turn into colon cancer because they have the highest amount of surface area. So villous are villainous. All right, let's talk about the genetic pre-malignant colon syndromes. So this is a set of syndromes, one of which we talked about already, and these are all genetic, so they all have family history. Now, the first one we already talked about, hereditary non-polyposis syndrome, that's a mutation of the HNPCC gene. The rest of them that we're going to talk about are mutations of the APC gene, and these are a little bit more severe, so we have to take these into greater consideration. So familial adenomatous polyposis. You should get 3 things out of those words. Familial, meaning that it's genetic, it's hereditary. Adenomatous, meaning it forms adenomas. Polyposis, meaning it is a disorder where you get lots of polyps. So what we have here is a mutation of the APC gene, and this leads to development of literally hundreds to thousands of polyps, even in childhood. Now, the problem is that unless you have a family history, which you should, but unless you have a known family history, you're not going to know about this until the signs of colon cancer develop. And so it's going to be very important to have a family history on every single patient. And this is usually going to be done in the pediatric stage. So usually the family history will be present, but you want to make sure that if you don't have any family history on the patient, that you get a family history. Make sure you ask your patient, is there a family history of any cancers? And if they say yes, colon cancer, make sure you ask them, how many family members, what age? Those are important questions. Now, like I said, most patients do have a family history of colon cancer. 75 to 80% of patients with FAP have a family member diagnosed with colon cancer. Not only diagnosed with colon cancer, but diagnosed with colon cancer at 40 years of age or younger. If you ever have a patient at whatever age that says, my brother or my cousin got colon cancer at age 37, that's a huge red flag. So at that point, you're going to be doing a flexible sigmoidoscopy on that patient right there. We're not going to necessarily do genetic testing. So as far as diagnosing, if you have a patient where you've got a family history that points you towards FAP, so a family member with colon cancer at less than age 40 years, or if the patient's been genetically tested for APC, that's going to be a presumptive diagnosis of FAP. It will be a diagnosis if they're genetically tested. So let's say you have your patient and they say, yes, I have a family history of colon cancer, and one of them got it when they were 35. At that point, you're going to be doing a diagnostic flexible sigmoidoscopy. And if it's a patient who's young, who's 5 years old, then you're going to start it at age 12. So whenever they're diagnosed, presumptively diagnosed, or starting at age 12 if they're a child. And you're going to repeat it every 1 to 2 years. And when a polyp is found, then you're going to proceed to a full colonoscopy. So we don't make the diagnosis, if they don't have genetic testing, we don't make the diagnosis when we just find one polyp on the flexible sigmoidoscopy, because that could just be a polyp. We could all get polyps. So unless they have genetic diagnosis, we're going to be doing the flexible sigmoidoscopy beginning at age 12 and repeating every 1 to 2 years, or the flexible sigmoidoscopy at whatever age they told you they've got a family member with colon cancer less than age 40. Once you find a polyp on flexible sigmoidoscopy, then you will proceed to a full colonoscopy. And the diagnosis on colonoscopy, if you're going to make a colonoscopic diagnosis for FAP, you have to have greater than 100 polyps. And that's going to warrant treatment. Now, if the patient has been genetically tested, and usually this will be a child, if the patient has been genetically tested for the APC mutation, then treatment will be warranted at detection of the first polyp on flexible sigmoidoscopy. You can skip the full colonoscopy because at that point you know that they're developing polyps. And the treatment is going to be surgical. You're going to take out their entire colon, and you're going to take their ileum and pull it through into the anal area. And so these patients will be continent. So total colectomy with ileal anal pull-through. And this is what it looks like on colonoscopy. So it's not going to be difficult to count 100 polyps here. You're not going to have to keep track. You look through here, and when you go through with your colonoscope, you won't need to count. You'll know there's more than 100 polyps. Okay, what is Gardner syndrome? Gardner syndrome is a variant of familial adenomatous polyposis, FAP. So what Gardner syndrome is it's a variant of FAP, but these patients also have a predilection of other soft tissue tumors, namely lipomas, osteomas, cysts, and fibromas. Particularly in patients with Gardner syndrome, they're going to have osteomas in the mandible. And a lot of times you're going to get this as a referral from a dentist. Why? Because you're doing x-rays on kids with teeth, and the dentist gets the x-ray and they see an osteoma. Dentists are trained to look for these things because these are certain things they're going to need to tell their doctor. An osteoma is very, 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 very obvious on x-ray. So I'll show you a picture of it. But these osteomas in Gardner syndrome thankfully tend to appear on the mandible or they probably tend to appear on the mandible because that's where we take x-rays of people on a regular basis. But osteomas will tend to present on the mandible. Now the symptoms, if you don't find the osteomas, if you just let the symptoms continue on, you may get painless lower GI bleeding, but most commonly you're going to see the osteomas on x-ray. You can also get multiple lipomas, supernumerary teeth, and epidermal inclusion cysts, which are just cysts that look like they're made completely out of skin, and they occur on your neck or on your arms, different places. The diagnosis is going to be colonoscopy with biopsy. So if you have a patient who has osteomas found on their mandible, then your next step in diagnosis is a colonoscopy with biopsy. Colonoscopy with biopsy if you find a polyp. And the treatment here, we have two options. We can approach this from a medical approach, and in which case we're going to give them the NSAID Cilindac, and that can actually induce regression of polyps. It works in about 80% of patients. Otherwise, we can use surgery as an option. Once we diagnose a patient with Gardner syndrome, after their first colonoscopy, they're going to need colonoscopy every 1 to 2 years, and we manage this like FAP. And so here are the osteomas. These are in the mandible. So on here, here, here. This one's not as obvious. Okay, juvenile polyposis. So juvenile polyposis is a predilection to develop hamartomas. So that sets it apart from FAP and from Gardner syndrome, because with FAP and Gardner syndrome, you have a predilection to develop adenomas, and adenomas are cancerous. Hamartomas really aren't. So while these patients with juvenile polyposis do have a slightly increased risk for developing colon cancer, it's not much higher than the general population, and so that plays a big role in prognosis. Juvenile polyps, juvenile polyposis, is not often symptomatic, but when it does present, it will tend to present as a painless lower GI bleed, and particularly it'll be in a pediatric patient. This can present in adults or in pediatrics, but when it presents in a pediatric patient, you tend to know that the chance of it being juvenile polyposis is relatively high. Now, there's another disorder in pediatrics that you should also associate with a painless lower GI bleed, and that is a Meckel's diverticulum. A Meckel's diverticulum is totally different. And we're not even going to talk about that now because that's in the small intestine and it's a pediatric disorder. What you should be getting in any child that presents with a painless lower GI bleed is a technetium scan. A technetium scan is going to help you differentiate Meckel's diverticulum, which would be a positive technetium scan, and juvenile polyposis, which would be a normal technetium scan. So in children, painless lower GI bleed could be Meckel's diverticulum, or it could be a polyp in juvenile polyposis. Now, the diagnosis is going to be confirmed when you do a colonoscopy, and the biopsy of a polyp, the offending polyp or whatever polyp is in there, reveals a hamartoma. And that will generally be the polyp that you find, particularly in a pediatric patient. So because this is juvenile polyposis, it's not just in children, but it oftentimes presents in children because lower GI bleeds are so uncommon in children. So biopsy will reveal hamartoma. And with juvenile polyposis, there are no changes in recommendation for surveillance. This is just something that you're going to note on their history, on their set of diagnoses, but you will continue to do the colonoscopy at age 50, every 10 years, every 3 to 5 years if there's a polyp, and so forth. Okay, and then finally some other diseases that are associated with colon cancer. So I didn't warrant these important enough to give too much talk to because they're primarily non-GI disorders, but they are associated with a slightly increased risk for colon cancer. So Peutz-Jeghers syndrome is primarily a disorder that presents on the skin, and it's associated with a slightly higher risk of colon cancer, but it's not going to change your surveillance recommendations. The way you will generally see Peutz-Jeghers syndrome is by hyperpigmented spots, and they tend to present around the lips and the oral mucosa, but you can see them also on the hands and the feet. A lot of times you're going to diagnose this in kids. Peutz-Jeghers syndrome, because of the nature of the disease itself, can present as a bowel obstruction. So in a patient that presents as a bowel obstruction, take a look at their lips and take a look at their hands and feet. If you see hyperpigmented spots, it might be worth testing them for Peutz-Jeghers syndrome, which would be a genetic test. Bowel obstruction, the number one cause, is most certainly not Peutz-Jeghers syndrome. But Peutz-Jeghers syndrome often presents as bowel obstruction because there's really no other way for it to present. And there's no treatment for Peutz-Jeghers syndrome other than treating the complications, namely the bowel obstructions, and the colon surveillance is the same, as I mentioned, as the general population, and this is a genetic disorder. Turcotte syndrome is not really a disease that is going to mean colon cancer. It's simply the fact that there is a genetic association between brain tumors, particularly gliomas, and colon tumors. On these patients, you may see café au lait spots. So I wouldn't really worry about having to diagnose this. Just know that there is a genetic association in patients with brain tumors to colon tumors if they have café au lait spots. And café au lait spots are just light brown patches, small patches on the skin. So patients with brain tumors and café au lait spots, think Turcotte syndrome. And so go back to Peutz-Jeghers syndrome, talk about those hyperpigmented spots. They can be pretty significant. I mean, you can usually, this is not something you see every day. So these blackish, brownish spots around the lips, these aren't just your everyday freckles. Particularly if you see them going up into the lips. You should definitely think Peutz-Jeghers syndrome. But they can be kind of subtle, like on this patient here. And here's some on the hand. And that is the end.